Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have our first returning guest, Dr. Gina Kirkpatrick. Dr. Kirkpatrick, why don't you tell us a little bit about who you are and what you do to remind everybody?
Hi, thank you for having me again. I am a board certified urologist, and I have a fellowship in female pelvic medicine and reconstructive surgery. So today, I think we talked about at our last lecture or podcast, the discussion of urinary incontinence. We came up with discussing some of the issues in female sexual dysfunction, which brings us here today.
Absolutely. So I asked, and she wanted to come back on the podcast to talk about sexual dysfunction, sometimes a much needed topic to be discussed and not discussed enough. So that's what we're going to do today. So why don't you, first of all, tell us what your credentials mean and why that makes you an expert in this field?
Okay. So I have the unique opportunity to be someone that can address the male sexual dysfunction issues as well as the female. So obviously, as a urologist, we are trained in residency. Most of our focus is on the male sexual dysfunction, and very little do we learn about the female sexual dysfunction. And I think as the training, because I finished training quite a few years ago, but I think now that we have more females in urology, I think some of the process of evaluating the curriculum and how much time we spend on female specific issues has increased. And so coming out of fellowship, felt that I was adequately prepared because I spent a year just seeing women for the most part. To be able to counsel my patients in a comfortable fashion where they would be able to open up to me about their sexual issues. So one of the screening things that we do for men when they come in for their yearly exam is to talk to them about their sexual function. And so I've just started to incorporate that into my visits with my women. And it may be a visit for recurrent UTIs or a visit for urinary incontinence or something else. And I always bring that subject up once we've kind of dealt with their issues and follow up. And what happens is that a fair number of my patients are postmenopausal. And so that means that the gynecologist hasn't seen them in quite some years. And so we want to really address that. And what I find is that quite a few of these women say, yeah, I do have issues. I have no desire to have sex. My husband bugs me with it. And yes, otherwise we have a very happy marriage. And so I now take it upon myself to make sure we address that point at some point during their care.
I think that's amazing. And I know you mentioned more women are going into urology, which is definitely happening, but it's still an underserved or underpopulated area for women. So I think it's awesome that you have done that as well. And then the other thing is, like you said, like men's sexual health is always discussed, right? I mean, even on the TV, right? Cialis, Viagra, that kind of stuff. But also I think the women are overlooked. So it's very important that we take the time today and in our specialties to address this. So how common is sexual dysfunction in women?
Yeah, so the data is sometimes not specific, like one source will quote 30 to 40%, but they don't necessarily include painful sexual activity as part of that dysfunction. Other sources have been as high as 50%, but that do include pain. And so it really depends on what data source you're going to. But I think it's pretty safe to say about 30 to 40% of women suffer from some type of sexual dysfunction. And so that leaves a pretty decent amount of women that have not been able to get the type of care that they need in that aspect. And unfortunately, it's really sad. I haven't had most men under 80 tell me that sex wasn't important to them. But I do get a lot of women over 60 that just say it's not important to us. I have a great marriage. Otherwise, I don't even want to talk. Well, they do want to talk about it because then when you bring the subject up and, well, what is the issue? So I guess I'll get into the segue, how we diagnose and categorize the women that have female sexual dysfunction. So we look at it, and Rachel Rubin, who is a guru she's a urologist as well, of female sexual medicine, has done a lot of research and a lot of new data and has worked with organizations that are putting out tons of great information for other physicians that are interested. And then obviously I'll give you some references so that you can put up on the podcast when we're done, just for people that are interested in getting more information. But when we talk about diagnosing it, we look at it from 4 tenets. We look at it, is it pain involved? Is your sexual dysfunction secondary to pain? Is it from lack of desire, arousal, or orgasm? In my mind, when I'm thinking about what treatment path we should go down, I use pain separate because desire, arousal, and orgasm to me are all kind of linked. So starting with the desire, arousal, and orgasm picture, we have a questionnaire in urology for men about their sexual dysfunction called the SHIM questionnaire. And there's something similar for women. One is the FSFI, and another one is a newer one that I just found about. It's a decreased sexual desire screener. And so it's about 5 to 6 questions. The FSFI can be really long, but they've abbreviated. And it basically gets to, have you had this condition 6 months or more? Do you have a lack of motivation for sex? Do you have a lack of desire for sex? Is this troublesome or problematic for you? Does it make you sad or does it make you concerned, et cetera? The motivation even goes so far to say, do you lose interest during having sex? Are you not stimulated when there's erotic stimuli in front of you, or as in a movie, or if you're participating in foreplay and you just feel nothing? And those people that meet that criteria, we basically diagnose with hypoactive sexual desire disorder. Okay. And it's really great because there are 2 FDA approved medications for that. Now, obviously, before we get there, we need to look at their medications because we know that there are a number of medications that can cause this lack of sexual desire. We know the narcotics can do it, the opiates. We know that some of the antihypertensives can do it. We know some of the psychiatric medications can do it. So obviously you want to rule out that as an issue, as well as ruling out pain as an issue, right? Because I do have some women that have had pain with sex and now they have no desire for sex and it bothers them as well. So you want to make sure you exclude that population. One of the medications that's been approved is filbanserin. Its trade name is Addy. People think it's the version to Viagra because it's a pink pill, but it is not. It works totally different. You take it at nighttime, 100 milligrams. And the caveat with this is that if you're a heavy drinker, I don't even put you on it because they say if you're going to have more than 2 cocktails at night or 2 glasses of wine, then don't take it that day. And if you do that most nights, then it's going to be useless for you. And then if you do have a glass of wine with dinner, they just say separate it a couple of hours before taking it. As far as its mechanism of action, it increases dopamine in the brain and it uses serotonin to boost the dopamine and the norepinephrine. It's about 60% efficacy. That doesn't sound great, but before, 10 years ago, there was nothing. Some of the side effects are dizziness, somnolence, nausea. But the nice thing I like about it is that there's no adverse events that have been shown in the clinical studies for people that are also on an SSRI or SNRI. So we don't have to adjust those medications, which is really, really good. I think alcohol is kind of like the caveat that I think that we have to be careful about.
Well, that's super important because SSRIs are obviously probably the most common medication that reduces sexual desire. Yeah,
exactly. Now, both of these meds that I'm talking about were FDA approved for the pre-menopausal population. So if you use it in a postmenopausal woman, you have to just tell them that the clinical trials didn't include postmenopausal women. Many people use it off label, and they do have some post-market studies that they've done that have shown that it's safe, right? And so it hasn't been a deterrent for any of my patients, but you just have to give that caveat. The next medication is bremelanotide. Vyleesi is its trade name. It's a subcutaneous injection that you inject about 45 minutes before sexual activity. And women describe it as like fire in the pelvis. All of a sudden, things wake up that they hadn't really remembered were there for a while. It is contraindicated if you have uncontrolled hypertension. It too increases dopamine. And I love how they describe it. I had to write this down. So in the information for Vyleesi, they describe it as it reduces your self-consciousness, it increases sexual imagery, and sensitizes women with HSDD to erotic stimuli. So it kind of works like Viagra as far as the timing of it, but it's an injection. And I tell you, the people that I've tried it on really do like it. I've had one lady that's had some hypersensitivity That's kind of the thing when you haven't felt anything for years and then all of a sudden you use this injection and things are waking up. It almost is like riding a bike. You have to get sensitized to it. So those are the FDA approved meds for HSDD. Some of the off-label that I use is testosterone for women. It's off-label because no one has taken the time to do any peer-reviewed, case-controlled clinical trials to look at its safety model as well as its efficacy. I think we have enough anecdotal data to know that it does work to improve sexual desire and orgasm and arousal in women. The bigger issue is, does it increase breast cancer risk or not? And because there's no data, you just have to tell your patient that you're not using a large amount of testosterone. With the testosterone, you really need to get your baseline hormone studies. I have a tendency to do everything because none of my patients seem to be too straightforward. Some people will just check the baseline testosterone, but you definitely should get your whole thyroid panel, your whole hormone panel, as well as a prolactin if they're having any altered menstrual cycle. So you want to make sure there are no issues there. And then once I start them on testosterone, you can do it in pellet, you can do it subcutaneous injection in women. You can also do it transdermally on the skin. And once I start them on it, the subcutaneous is usually an injection every 10 days. If it's transdermally with a cream, it's daily. And with the pellet, once you put the pellet in, it just depends on where their levels are in about 3 months when they need a new one. So it's important you check the labs. For me, I check the labs at 6 weeks to see if they're responding to therapy appropriately. Some people are really super therapeutic in that their testosterone shoots up really high. And so those people you really have to back off, which is why I typically don't put in pellets initially, because once it's in, right? You can't do anything about it. But once they're responding appropriately, I'll check the labs again at 3 months. And then depending upon if we change the regimen, it may be another 3 months and then 6 months and then a year. Minimally for me, it's every 6 months. I know some people check yearly. It's just a personal preference. I kind of manage my male testosterone supplementation population the same. Some of the side effects of testosterone supplementation in women, which is why you really need to check and make sure they're not super therapeutic, is the virilization. So they can keep your voice, clitoromegaly, hair loss is kind of like the male pattern baldness, hair loss.
Hair growth too, right?
Yes, hair grows in places that they didn't before, including their face. So acne and sometimes hypersexuality. So you have to be really, really careful with it. But like I said, it is for the people, especially younger women that don't want to be on a medication. They don't want to inject themselves. They're maybe perimenopausal. They really do well with it. But like I said, you just have to be really super careful about counseling them about the lack of data regarding the long-term safety of it. And most of them choose to do that. I mean, obviously you screen out the population that has a strong family history of breast cancer. And I'm probably maybe more conservative about that, but because there are other options for them. But yeah, that's definitely a good treatment as well.
Are the women still at risk for elevated hemoglobin, hematocrit, polycythemia?
Yeah, so we don't, I check it because as long as they're not supra therapeutic, no.
Okay.
But my 6 week labs, my first 3 month labs have tendency to be all those again, just because of my level of paranoia, but it's probably overkill. But yeah, definitely, as long as they're not super therapeutic, there's not an additional risk. But yeah, thank you for bringing that up as well.
And are there standardized testosterone levels for women? Yeah.
There are not.
Yeah.
We try to keep the free testosterone level within normal limits, like 0.6, 0.8 when you calculate it. And we just try to make sure that they use it appropriately and don't become super therapeutic. That's a really low number.
Well, how are you defining super therapeutic if there aren't
So a
baseline?
woman that comes to me with a 200 of testosterone, yeah, right. They're probably having some symptoms.
Okay.
Anything 60-ish less it's okay. And again, I'd probably pay more attention to the free testosterone level than the total, as long as the total is not super therapeutic. Like say theirs is 30, but they're within a good free testosterone range, I'd probably just not change anything. So that's HSDD. Do you have any questions about that?
I don't, but as a definition, like of sexual dysfunction, you would include those 4 things, right?
Yeah.
pain, like rule
Well,
out pain, right?
exactly.
But
Pain is part of, yeah.
desire, arousal, and orgasm.
Mhm.
Okay.
Yeah, so
Okay.
that's kind of how we classify when we're trying to stratify
Mhm.
what potentially could be their issue. So then for next in that stratification, then we have the pain, right? That's a
Mhm.
whole nother animal. So pain, for me, I kind of think about, are they perimenopausal? Are they premenopausal? Or are they postmenopausal? If you look at pain, let's deal with the one that I see quite often is the genital urinary syndrome of menopause. And so that's
Mhm.
basically postmenopausal women, they get burning with urination, frequency, urgency. They think they have a UTI every week. They have vaginal burning. They have lack of lubrication with sex. They have lack of arousal during sex. They have vaginal atrophy, which causes vaginal dryness and pain during sex. And sometimes they'll even have postcoital bleeding. And so those women, you really try to give them initially, if they are not high risk for breast cancer, there's been data that says it's safe to use vaginal estrogen in women. So the Women's Health Initiative, I think it was 2017 study, basically said cardiovascular disease, breast cancer, and endometrial cancer are not caused by vaginal estrogen use. So how we use it is 1 gram nightly for 2 weeks, and then 1 gram twice a week. If you use the Vagifem, which is the pill, you'd use it the same way. You just use the pill instead of the gram. And we found that also you can use Zoza, which is DHEA, but you have to use that daily. So all of these things help to remodel the vaginal epithelium, they increase the blood supply, and they help to resolve the issues. All of the genital urinary syndrome and menopausal issues are primarily addressed with the vaginal estrogen, including the improvement in sexual arousal and sexual performance. So that is one of the things that when we talk about post and perimenopausal women, CO2 and radiofrequency ablation lasers, vaginal lasers, have been in the market for years for the same thing. They have had difficulty in having insurance paying for it because it's a cash pay service, but it too is a good option. They do require maintenance. So you're going to have something done usually on a yearly basis with these. I think RFA, you can probably stretch out a little bit longer, but they do require maintenance, but it also is a good treatment as well.
Some of those machines that we hear about
Mhm.
that.
Yeah, Mona Lisa,
Yeah.
Viviv, some of the other RFA lasers as well.
Mhm.
Yeah, that's what you hear about all the time.
Got it.
And their market is usually vaginal laxity and menopausal changes. Some women that are kind of in that postpartum state on a hormone blockade, and they get this all of a sudden dry vaginal tissue, vaginal atrophy, and painful sex. There are some people that use it for that as well. They've had some good results. So it's a good tool. Problem is insurance doesn't pay for it. And a lot of people don't have the means to pay. The treatments are usually anywhere between $2,500, $3,000 for a treatment regimen. So that also is a good off-label use. I do have some patients that say, you know what? My mom died of breast cancer. I know what you're telling me. I still feel uncomfortable about it. There is a non-hormonal alternative called Reverie, and it's hyaluronic acid. And there's a new product on the market that I've seen advertised. I'm not familiar with it, but Reverie is made by a pharmaceutical company called Bonafide, but it is over the counter. You just have to go to their website and order it. You use those suppositories 3 times a week. It does the same thing as the estrogen does. It takes longer though. Estrogen, you start to see some improvement in about a month in most people. Not completely cure, but definite improvement in a month. Reverie, I've seen from my patient population. Again, this is really anecdotal because I tell them stick in there at least 3 months, right? Because it takes longer. It's a non-hormonal option. It does remodel the vaginal tissue, the epithelium, increases the collagen, and improves the dyspareunia symptoms that patients have.
Well, it's important to even tell people that the vaginal estrogen can take a month because some people,
Yes.
they just want immediate
Yeah,
results,
right.
right?
I
Yeah.
saw a lady just like a couple of weeks ago, and we're talking about this. I did a cystoscopy on her. Her vaginal tissue was just like sandpaper, and it wasn't lichen sclerosis. It was just literally, which is another condition that'll cause kind of dry, painful sexual activity in tissue. It was clearly just vaginal atrophy. And I said, listen, and she was almost jumping when I was just doing her cystoscopy from the cold water hitting her vaginal tissue. And I put her on one of the vaginal estrogens, and I see her back, and like for her follow-up, maybe 2 weeks later, I said, "So you still use the vaginal estrogen?" She said, "No." And I said, "Why?" She said, "It didn't work." I said, "I just saw you 2 weeks ago." "Well, I used it like a couple of days and I didn't feel better." And I thought, no. So that must have been an error with me not saying
Right.
stay on it. So
Right.
now I've learned to just reinforce that every visit, stay on it, whatever. So that's the genital urinary syndrome of menopause, pain with sex. Then you've got these people that have pelvic floor dysfunction, they have pain with sex. So have pelvic spasms is important to determine. Sometimes I'll add, most of the time I can get to it by where their pain is, right? Obviously, you've got to do a detailed exam, do a Q-tip exam, and you palpate or feel their pelvic floor on the bottom. And if they've got hypertonicity or they say ow, or they have pain there, then pelvic floor therapy is the first line of therapy for them, because for people that don't know what pelvic floor therapy is, they're physical therapists that really are specially designed in treating disorders of the pelvic floor. So they do myofascial release and they do biofeedback and other things that kind of help loosen that tissue and those muscles, because it's just a tight muscle down there, and to help them have a little bit more flexibility, and it's just not so painful with sex. Sometimes we have to give them suppositories, like they can have a baclofen suppository they put in the vagina, or sometimes I'll do diazepam or Valium. I have one patient that's been managing for years. She just uses Valium before they have sex. One of the suppositories, like the night at dinner, and then by the time they're having sex, she can tolerate it. And so those are options as well that we use to treat it. Sometimes you have to do trigger point injections with steroids, or sometimes with Botox in the pelvic floor. And so basically, we just kind of go through the algorithm to see what works for them to get them a little bit more comfortable. And the pelvic floor is just not with sex. Sometimes they have difficulty emptying their bladder. Sometimes they have difficulty evacuating their stool. So it can be a multifactorial problem for them. So we talked about postmenopausal pain. Oh, then the other type of pain is the vulvodynia, or the vestibulodynia, which is some women have pain over their whole vaginal wall. So you do the Q-tip test all around and everything hurts. And sometimes it's hormonally mediated. Sometimes it can be women that are undergoing IVF, and those hormonal changes will cause it. Breastfeeding, oral contraceptives, and oophorectomy, hysterectomy with oophorectomy, removing the ovaries. And then sometimes they're on breast cancer treatment. There's been some data, some anecdotal data, that people are really using testosterone as well as off-label for vulvodynia, in hormone-mediated vulvodynia, and seeing if they get some relief from that. Most of those people that have hormone-mediated vulvodynia, it's usually a transitional kind of period. I'll just try to give them things to get through whatever they're going through, as far as what I think the cause of their pain is. And then once they've gone, like if they're on contraceptives, perhaps select another type of contraceptive and then see if that resolves it, and then kind of go down the same algorithm. But that's another one that also is really hard to treat because everything hurts, right? And so there are creams that you can give them. They also sometimes will benefit from some of the suppositories. And then there's the testosterone used around the vaginal introitus and the vulva and the labia. So those two, labia minora. So those two.
So topical.
Okay. Absolutely. Okay. So I think that kind of summarizes the big ticket items of female sexual dysfunction. But like I said, it's like peeling an onion. You get into one issue, and then lo and behold, there are like 3 or 4 or 5 other issues. I think it's important when you're counseling patients that sometimes it's not just physical, it's psychosocial. So sometimes they need the physical, the things that we do medically, but then oftentimes they also need some psychological counseling about their issues, especially if there's a history of abuse, if there's a history of cancer. There actually is a large cancer survivorship, sexual dysfunction practice that's kind of evolving in some of the cancer centers. So that also is important because the way that they view themselves sexually, sometimes they become asexual or they feel their spouse sees them as an asexual individual after they suffer from some cancer. So a lot of these things are all intertwined. So it's important to address every issue with them.
How important is communication with the partner?
Oh, yeah. That's where becoming a urologist really helps, right? Because especially so I'm a general urologist in Tampa and female urology in Tampa, but sometimes your time is limited, right? You've got tons of patients, you got kidney stones, bladder cancer, et cetera, urinary incontinence. But in my practice in Orlando, which I only do female, sexual health for men and women, I encourage the couples to come together.
Right.
And we can go through the issues together. Sometimes the women want to come by themselves initially, and then we talk through what their issues are and then bring their husband when we decide kind of what our treatment plan will be. But it is so very important. And I'll tell you, this is a funny story, and it works both ways, right? So I've heard of situations where a male patient comes to you and he's like, I want to get on these meds. I want to get on some ED meds. I'm ready to start having sex again. It's been, 7 years? And then the wife comes to you and she's like, no, please don't do that. Don't do that. But it's great because it opens up a conversation for me to say, well, what's the problem? Why don't, and they'll have a great relationship. In this particular situation, it really was, she had HSDD, and it wasn't because of abuse and it wasn't because of pain, but after not having sex for so many years, she just lost her desire for it. And women are wired a little bit differently than men when we talk about our hormone changes. Men have testosterone till they die. Most of them do, whereas our estrogen can drop off the map as well as the testosterone. And so it makes perfect sense. We become mismatched as we get older, but it does present a really unique opportunity for me to counsel both of them. So I love that.
Yeah, I think it's great. I think you were definitely the provider that said you prefer that they come together, like to work on all the issues at the same time. Yeah,
absolutely.
Do you have any like cultural or societal factors that you end up seeing?
Well, let me think about that. Probably, there are certain cultures that just don't want to talk about it. So, for the women, they just don't want to discuss it. And I respect that. I do the screening, kind of, is there anything else you want to talk about? Or are you having issues sexually? And some cultures just don't feel comfortable talking about it. And we just leave it there.
Okay. Yeah. And they probably wouldn't be coming to you in the first place.
Yeah, exactly. Well, for the women, they're coming to
Mhm.
me for something else. And that's not an issue. And that's fine. But I love when the ladies tell me they have a problem and they want a solution.
Mhm.
But you'd be surprised the number of them that have said, I'm 65. I don't need to have sex. I'm pretty sure I'll never have sex again. And I'm okay with that. And they're like, I don't desire to have sex. I just want to come home and drink my glass of wine and do whatever I do. But when you probe a little bit more, you find that they still have an interest in sex. They just don't have a desire in it. And then you can kind of work with them.
Okay. Are there any common misconceptions that you want to dispel regarding this?
That's a good question. I think for the most part, the biggest misconception in the general population is that women really shouldn't be concerned about their sexual satisfaction, because what do? We just lay there, right? So like your husband's wife, you do your womanly duty. And I think a big misconception is that women don't enjoy sex and that they don't care about it. Now, obviously in the younger population, less so because of social media, and there's so much more information available to you just by looking at your phone. But, in the 60 plus population, is a whole different generation. And I think these women just feel like after they get 60, sex is not important and they shouldn't really be concerned about it.
Are there any lifestyle changes that you recommend to patients?
Well, obviously, just like with anything else, if they're out of shape or overweight, we see more testosterone issues in men that are morbidly obese, obviously, because of the aromatization of the testosterone to estrogen. But women more so, if they don't feel good about themselves physically, then they're certainly not trying to have sex. They're getting
Mhm.
undressed in the bathroom, etc. So I try to encourage them self-care. If they can afford to go to the spa, walk, we have a great gym in our building, or the building on the campus where I am that's pretty reasonable. Go over there. It's a good support group for women, and you can just get a little bit of exercise, because also we know the benefit of endorphins and how you feel every day, right? So just trying to get them to be a little bit more active. I try to encourage that. Obviously, just as a urologist, I'm on them about kind of what they drink and how much they drink and when they drink. Because part of the GSM, the genital urinary syndrome of menopause, we also see urinary issues as well.
Right.
So it's kind of talking them through all of that and the benefit that they get, not just from their health, their general health, but also in their urinary symptoms as well.
Yeah, I think your comments about the men and testosterone and their weight, I think that would be a great topic for another podcast that maybe we have to come back on to for the men, right?
Yeah, I think out of fairness to the men, we should do one on
Yeah.
sexual health and issues in men, and kind of some of the common misnomers. And there's been some discussion about even increasing penile length or girth. And so I get some men that have seen a lot of YouTube and other things
Right.
about that. So I think it's good to kind of give them some real American Urologic Association guideline. This is really what urologists do for these issues. And because there is a lot of miseducation on the men's sexual health issue as well.
Yeah, absolutely. Is there anything else that you'd like to share with everybody?
I think we covered everything. I will, like I said, I'll give you references for good resources for the physicians that may be listening that are interested. I know that a lot of the gynecologists in the area probably don't have the time to dedicate to spend on talking about the length of these conversations that you often have. So I've had some nice gynecologists send their patients to me for this. I'm seeing new patients in the Advent Health Wesley Chapel office, general surgery and urology office. So I would love for them to come see me if they have any issues or any other urologic issues. And if they're in the Orlando area or don't mind driving, they're more than welcome to come see me in the Orlando office as well.
So to find you, just look on the Advent Health website, or is there?
They can just Google.
Google.
So the Orlando office is the MV Medical Orlando, and it's just www.mvmedicalorlando.com. If they're interested in Tampa, then it's the Advent Health website, and they can find me on there. And the office number for the Wesley Chapel office is 813-929-5809.
Is it MV as in Victor?
N is in new, V is in Victor.
Okay, N.
Yeah,
Okay.
NV Medical Orlando. So yeah, I would definitely love to see anyone, even if they have questions. I do virtual visits through both practices. So, definitely we need to do a physical exam, but even if they just have some questions that they want to run by me and see if it's appropriate for them, I'd be more than happy. The Orlando office is 407-730-4244.
Awesome. All right. We'll put all that in the show notes as well.
Okay,
so
perfect.
Thank you so much for coming back
Thanks.
on, and hopefully we'll see you again.
Awesome. Okay. All right. Have a great day.
All right. Take care, everybody.
Okay. Bye-bye.